Okay, I presume that how many of you have done cystoscopies? Okay, only one person out of the whole lot. Come. So, in any OPD, whether rural areas, urban areas, what percentage of patients do you think will have urology problem? 35. Okay. What about this side? ओपीडी में आप 100 लोग देखने से कितना लोग का यूरोलॉजी प्रॉब्लम होगा? Okay, the consensus here seems to be 10 to 15 and 30, but actual data shows that it's only about 5%. But even 5% is a very large number because in our country, how many crores of people are there? So 5% of that is quite a lot. So it is a very significant problem. But then most of the rural areas, the patients who need evaluation for urology problems, they can't afford to go to a urologist because there is always a shortage of urologists. Not even only in India or rural India, even in America has a shortage of urologists. Canada has shortage of urologists. Germany has shortage of urologists. The only one or two countries in the world which has a sufficient number of urologists to tackle the problems. But why is non-urologists or general doctors, MBBS doctors or general surgeons also not able to do urology work? क्यों? What do you think is the reason? Lack of training. Okay, one is lack of training. During MS time, we have a 6 months posting in urology, so all the general surgeons should have had some urology training. Okay, that is one of the reasons. Any other reason? That's a very important reason that he said, because you need training to tackle the urology problem. Come. What is the other problem? Okay, they will not know, but what about the hospitals? Do they have any problem in providing the urology equipment to everybody? Okay, in other words, is it cheap or is it expensive? See, normally if we have to do just a cystoscopy, the cost is huge. It's at least you'll need the telescope, you need the cystoscope, then you need the camera, you need the monitor, you need the light source, you need so many things. Like if you look at the slides, you'll know. So what are the parts of the cystoscope? We have various types of cystoscopies. One, you have the rigid cystoscope, then you have the flexible cystoscope, and this what we are calling this is a laptop cystoscope. So which one do you think is cheaper between these two? Rigid. Yeah, rigid is less expensive, but what is the advantage of flexible? Flexible, only advantage is that the patient can lie down and you don't have to put them in lithotomy position. It's not, I know it's not a very comfortable position for people to lie in to do any procedures. While the flexible one, you don't need all that. But then doing any procedures with the flexible is more difficult. Okay. So most of the people will use the rigid one. And what are the common indications? Why do you have to do cystoscopies? If somebody has blood in the urine, you need to find out where the blood is coming from, and whether it is actually microscopic hematuria, where in the lab tells you there is blood in the urine, or gross hematuria. You still need to find out where the bleeding is from, because sometimes it can be from cancer, and if you leave it alone, it will take a long time it will spread and it will be difficult to heal. Infections, stones, there are a lot of other causes which, so this is one of the most common indication. Then for evaluating the lower urinary tract symptoms, Okay, so this is where you need to learn a little bit about what are the symptoms. Okay, can somebody volunteer to tell me what happened? How did he pass urine?
कौन बताएगा कि आपने टॉयलेट कैसे किया, प्रोसीजर क्या था?
So how did you pass urine? How will you describe physiology? I mean, there's a lot of things you don't notice it, but then what happened? How do you know? How did you pass urine? How did you find out that you need to pass urine? Hmm?
Nervous system.
Nervous system.
Very good.
But who gives information to the nervous system?
नर्वस सिस्टम को किसने बताया? हमारे ब्लैडर ने बताया.
Okay, first thing is you have the, I mean, you don't always feel like passing urine. Okay, only when you had, when the bladder reaches a certain volume, you feel like you want to pass urine. Okay, so normally that volume is about 350 ml or 400 ml. But before that, do you know, do you have the sensation that you have urine in the bladder? So when will you know that there is some urine in the bladder? At what volume? 1 ml, can you find out if there is urine in the bladder? 10 ml, 30 ml, 50 ml. When will you know that there is urine in the bladder?
250 to 400. 250 to 400.
Okay, so usually it's about 100 ml, 100 to 150 ml. You know that there is urine in the bladder. That's called the first sensation. Below that, once you pass urine, you won't feel like there is any urine in the bladder. Okay. And then normal sensation, I said, when it fills about 300 or 400 ml, the bladder sends nerves impulses to the spinal cord, which tells the brain that there is enough urine to, volume or urine in the bladder to pass urine. So then what happens? Do you immediately pass urine or what do you do?
रोक सकते हैं ना, so you still stop.
Okay, so normally children don't do that. Children, what happens? Small child, whenever the bladder is full, they'll immediately pass. But adults don't do that because you are overruled by the brain. So you go, you first find out if there is an empty toilet, then you go there, you lock the toilet, then you undress. Only then the brain will send impulses to the sphincter which prevents a leak to pass urine. Then the muscle starts contracting. The bladder muscle is called detrusor muscle. And in men, when it reaches about 60 centimeter of water pressure, then the sphincter opens and you start passing urine. Women, because the urethra is shorter, it's about 40 centimeters of water. And then once you pass urine, what happens? Do you empty the bladder fully or still there is some urine left behind? Normal people should totally empty the bladder. Okay. So then when does this is a normal way it happens. So when do you get these symptoms? So what are the problems? How do you get the symptoms? Say imagine old man, he has a prostate. So when men reach an age about 40, it starts growing. So then it keeps growing. Then it starts blocking the passage of urine. So what will be the symptoms? What will be the first symptom which will occur? Okay. Before that, say what happens, say first symptom which will occur is what we call hesitancy. So usually now what happens, as soon as you go to when you are childhood, you go to the toilet, immediately pass urine because bladder has to generate only about 60 centimeters of water. But if there is some block and only if the bladder muscles are able to generate 80 centimeters of water, then what will happen? Will you be able to immediately pass urine or it takes a little while? Because bladder muscle has to contract and generate 20 centimeters of pressure more than the normal. So if it takes 2 seconds or 3 seconds to start build a pressure of 60 centimeters. For 80, it will take 4 seconds. So that is the first symptom which occurs. It's called hesitancy. Then it becomes what we call the poor stream. So normally they say when you're a childhood, you can write your name while you're passing urine. But as you grow older, you can't do all that things because the stream is not powerful enough. Okay. Then finally, you'll reach a stage what is called, it's called intermittency. So there what happens is they say, imagine you're walking in a railway platform. You have a heavy suitcase. So if the suitcase is light from one end to the other end, you can comfortably walk without any problem. But the heavy suitcase, after some time you'll keep it or change from one hand to the other hand, then walk further. So similarly, when there is more obstruction, then bladder muscles cannot contract continuously. So it has to put in a lot of effort. So it will contract a little, relax, contract and so on. So that is intermittency. And finally, you reach a stage where you cannot lift the suitcase anymore. So then you land up with incomplete voiding. So normal capacity, say if it is 400, you will be able to empty only 300 ml. So then what happens? The frequency keeps increasing because actual volume which is usable is very less. If you produce 100 ml of urine in 1 hour, so within 4 hours it will fill up if the bladder has become totally empty. But after passing urine, if you have 100 ml in the bladder, then within 3 hours it becomes full. So then the frequency keeps increasing. And initially you will notice the frequency more in the night because daytime you won't remember how many times you go and pass urine. But if you have to get up in the night to pass urine, you will remember. So these are the symptoms which occur with the lower urinary tract symptoms. But why do you have to do a cystoscopy and other evaluation for these symptoms? Ask them, why do they have to evaluate these symptoms? So these are the symptoms. When they have any problem, can they just assume that it is due to obstruction and do operation? Okay, there are 2 tests we needed because it is not only the obstruction which is due to prostate which causes this problem. I am sure there are so many ladies also have the problem and none of them have prostate. So then why do they get the problem? Because there are a lot of other conditions which can mimic all these symptoms. If the nerves from the spinal cord, if it goes to the bladder not working properly, that can cause a problem. Or there is infection in the bladder, that can cause irritation and cause problem. And then if there is a block, need not be only prostate, it can be any other things like stricture which can cause a problem. So all these things will require 2 things. One is called the cystometrogram or bladder pressure studies. So we need to measure how much the bladder is generating, how much pressure the bladder is able to generate. So if you put a pressure sensor inside the bladder, what pressure does it measure? Is it only the pressure in the bladder or is any other pressure? So the pressure which the pressure sensor will measure is a combination of the pressure which is generated by the bladder muscles and the abdomen. Okay. So what happens is that we need to find out how the bladder muscles are working. We need to do what is called a urodynamic study or bladder pressure studies. The conventional machines which are available now, they use a catheter in the rectum to measure the abdominal pressure. So from the total pressure, they subtract that to give the actual pressure which the bladder muscles are generating. And it's not a very pleasant thing to have one catheter in the bladder and one catheter in the rectum and keep lying down for a long time. So to shorten the procedure, we used to pass one more catheter to fill the bladder quickly and do the studies. And also we ask the patient to pass urine in front of the nurses or somebody who is doing the study. which is again artificial setting. So the results which we get from conventional bladder pressure studies are not very accurate. So what we have developed is we have developed a new machine which has only one catheter which or infant feeding tube which goes to the bladder, and there is a sensor here which measures the pressure, and it records to either a computer or iPad. And then to subtract the abdominal component, we use artificial intelligence or the computer knowledge artificial.
सॉफ्टवेयर के थ्रू हम फिर वो ब्लैडर का जो प्रेशर है वो जान पाते हैं और एब्डोमिनल प्रेशर को माइनस करते हैं.
So how we do, I mean, you need to learn especially how to do this bladder pressure studies.
ब्लैडर प्रेशर स्टडीज करना भी हमें सीखना चाहिए.
So the first thing you do is, whenever a patient,
का नाम है यूरोपाइन,
UROPINE. Europine.
जी.
okay, the first thing you do is you ask the patient to empty the bladder and then come.
तो सबसे पहले हमें ब्लैडर को पूरा खाली करके पेशेंट को बोलेंगे कि अभी आप बिल्कुल अपना जोर लगा के जो भी है खाली कर लीजिए अपना, फिर आइए हमारे पास ताकि हम अपनी स्टडीज चालू कर सकें.
And you have to again, because it's an invasive procedure, because you are passing a catheter, it's better that they receive a dose of antibiotic also.
एक डायबिटिक एक एंटीबायोटिक डोसेज उसको पहले ले लेनी चाहिए क्योंकि हमने एक कैथेटर भी डालना है ब्लैडर में, तो कहीं उन्हें इन्फेक्शन.
Okay, then you drape the patient, clean and drape, and under sterile circumstances pass a 5 French infant feeding tube.
इन्फेंट फीडिंग ट्यूब आप सब जानते हैं, 5 फ्रेंच इन्फेंट फीडिंग ट्यूब तकरीबन बहुत पतली होती है, 2 mm के आसपास होती है. उस इन्फेंट फीडिंग ट्यूब को अगर हम डालते हैं बड़ी आसानी से वो पेशेंट के यूरेथ्रा से,
Then you connect that to the machine and then start the machine.
और फिर वो इन्फेंट फीडिंग ट्यूब को एक आईवी ट्यूब से या किसी एक ट्यूब से कैथेटर से इसमें कनेक्ट करके मशीन को चालू करते हैं.
And the machine will also ask you the symptoms. What are the symptoms of the patient, whether increased frequency or nocturia or urgency or urgent incontinence. Those symptoms also have to be entered into the iPad.
तो वो जो पैड है हमने जो डेवलप किया है, उस पैड में हमको डालना है पेशेंट का नाम, क्या तकलीफ है आपको, रात को ज़्यादा आता है, दर्द होता है पेशाब करने के वक्त, रुक रुक के आता है, पेन होता है या पेशाब निकलता ही नहीं है, या हर वक्त ऐसा लगता है कि पेशाब हो रहा है, तो ये सारे सिम्टम्स जो है हम मशीन में डाल देते हैं.
Okay. Then you have to calibrate the machine for the computer to understand what is happening.
फिर हमें कंप्यूटर को थोड़ा सा सिखाना पड़ता है कि ये पेशेंट को अब ट्यूब लग गई है, अब बैठ जाओ, लेट जाओ, इस तरह से पेशेंट.
So first you have to make the patient cough, and then check the pressure, how much is there in the when the patient is lying down. Then you have to make the patient sit up and record how much is the pressure when the patient is sitting up, and then make the patient stand and record the pressure, how much it is when the patient is standing.
तो कंप्यूटर को थोड़ा सा ट्यूनिंग करने के लिए मशीन के साथ ट्यूब लगा के उसके बाद हम पेशेंट को बोलते हैं कि आप खड़े हो जाइए, बैठ जाइए, लेट जाइए, खांस लीजिए, तो वो देखते हैं फिर मशीन में कि हाँ प्रेशर चेंज हो रहा है, क्योंकि बैठने के प्रेशर में बढ़ जाता है ना प्रेशर, खड़े रहो तो और बढ़ जाता है, लेट जाओ तो कम हो जाता है प्रेशर. इस तरह से चेक किया जा सकता है और मशीन फिर रेडी हो जाती है.
And then after that you can just leave the patient to do whatever they want, because the machine will automatically keep recording the pressures which are inside the bladder.
फिर ये मशीन अपने आप रिकॉर्डिंग चालू कर देगी, आपका भी कोई खास काम नहीं है. फिर पेशेंट को बोलिए आप रिलैक्स करिए, पानी पियो, नींबू पानी पियो, चाय पियो, ताकि थोड़ा लिक्विड इनटेक होता रहे और किडनी ज़्यादा से ज़्यादा यूरिन बनाती रहे और उनका ब्लैडर जल्दी से जल्दी फिल हो. फिर भी आधा 1 घंटा लगता है.
Only thing I have to make sure is to tie the infant feeding so that the infant feeding tube does not come out.
इन्फेंट फीडिंग ट्यूब को यूरेथ्रा से जैसे बाहर आ गई ना, उसको एक धागे से लेके बांध के ऐसे करके हम कमर में बांध लेते हैं ताकि वो अपने आप ही ना गिर जाए.
Okay. And when the patient wants to pass urine, he or she has to pass in a container that you give them.
अब जो भी यूरिन अब उनका लीक हो रहा है या निकल रहा है या वो वॉइडिंग कर रहे हैं, तो वो मेजर करना है हमें. तो जरूरी है कि एक कंटेनर में ही हम उनको यूरिन करवाएं. वॉइडिंग जो है वो मेजर करना बहुत ज़रूरी है. क्यों ज़रूरी है? हमें समझ में आना चाहिए कि वॉइडिंग कितनी हो रही है.
And then after they finish passing, you open the infant feeding tube and find out how much residue is there
तो
after they pass urine.
तो आपको पेशेंट बताएगा हाँ थोड़ा थोड़ा लग रहा है, फिर बोलेगा हाँ आप ज़्यादा लग रहा है, फिर आप वो बोलोगे ठीक है आप कंट्रोल करिए, आप बोलेंगे, फिर आप पेशेंट को क्या बोलेंगे, रुको रुको रुको, तो वो पेशेंट बोलेगा नहीं अब मैं नहीं रुक सकता, दैट्स व्हेन तब आप उनको बोलेंगे ठीक है आप वॉइडिंग करिए। तो जब वॉइडिंग करेंगे, क्योंकि इन्फेंट फीडिंग ट्यूब है, पतली सी है, तो ट्यूब के बीच में से नहीं आएगा अपना यूरिन, क्योंकि वो तो मशीन के साथ कनेक्टेड है, ट्यूब के साइड में, इसलिए इन्फेंट फीडिंग ट्यूब है क्योंकि पतली ट्यूब है। और वो वॉइडिंग करेंगे, जब वॉइडिंग कर लेंगे उसके बाद फिर हम जो है ट्यूब को बाहर निकालेंगे। वॉइडिंग का आपको पता लग जाएगा कि कितना यूरिन आया, समझो पेशेंट ने किया 100 ml, अब आपको ये भी तो चेक करना है कि कहीं वापस बचा तो नहीं है उसके ब्लैडर में, ये भी तो चेक करना जरूरी है ना। तो आप क्या करेंगे, मशीन से खोल लेंगे, हमने खोल लिया पेशेंट का ट्यूब जो है, और उसको फिर हमने ड्रॉप कर दिया नीचे। ड्रॉप करने से क्या होगा, ग्रेविटी से जो अगर कुछ है पोस्ट वॉइड रेसिड्यू जो बोलते हैं ना, वॉइडिंग के बाद जो यूरिन ब्लैडर के अंदर रह गया वो क्या है, उसे क्या कहते हैं, पोस्ट वॉइड रेसिड्यू। क्या कहते हैं, फिर से बोलो एक साथ, पोस्ट वॉइड रेसिड्यू। नींद तो नहीं आ रही ना सब?
Okay, so the reason why we are doing it is that so far the computer records only the pressures according to the time, but it doesn't know how much volume is there inside the bladder. So only when you give the information about how much volume that patient voided and the post void residue, then the computer will calculate when you got the first sensation, how much is the maximum voiding pressure, how much is the post void residue, all the necessary information is obtained and we will give it in a graphical representation.
तो ये जो है कंप्यूटर फिर कैलकुलेट आप डालोगे, वॉइडिंग रेसिड्यू 100 ml था, पोस्ट वॉइड रेसिड्यू 200 ml था, तो इसका पोस्ट वॉइड रेसिड्यू बहुत ज़्यादा हो रहा है। हमारे पास एक पेशेंट आई थी, सर के एक पेशेंट थी, उसका पोस्ट वॉइड रेसिड्यू 1 लीटर रेसिड्यू, क्योंकि उसे पता ही नहीं था इतना ले लेते उनकी ब्लैडर मसल।
Okay, so this test, which is called urodynamic study or bladder pressure studies, will give a information about how the nerve supply to the bladder muscles are working, how the muscles are working, and then after that you need to do what is called the cystoscopy. That will give you various findings. So if there is a stricture, see this is the normal circumference of the urethra, but then if you notice the patient is passing only through the small hole there because he has developed a stricture.
वैसे ही जाना रहता है, नॉर्मल देखोगे तो बड़ा रहेगा।
So this is the prostate gland is enlarged. So there is hardly any space between the two enlarged lobes for the urine to come out. So this is how it causes obstruction. Okay, so this is called a ureterocele which causes obstruction. This is a diverticulum. These are cancers in the bladder. The tuberculosis and so all these things. So if we do a urodynamic study and also do a cystoscopy, you can diagnose almost all the problems which are there in the lower urinary tract. Okay, so now next thing is you need to learn how to do a cystoscopy. Okay, now we can all come and stand here, we will show you and then you can try it yourself.
अभी ब्लैडर प्रेशर स्टडीज का इंट्रोडक्शन दिया था, अब हमको सिस्टोस्कोपी सिखाई हो। तो अगर आपको नजर नहीं आ रहा है तो जहां भी आप कंफर्टेबल होते हो वहां से देख लीजिए कि सिस्टोस्कोपी कैसे किया जाता है। सर आपको डेमोंस्ट्रेट करके दिखाएंगे कि सिस्टोस्कोपी कैसे करते हैं।
Okay, so this is how you hold the cystoscope. So what is the advantage of holding it between your index finger and thumb? It's easy to rotate and move whichever direction you want. So if you hold like this, then you'll have to do all sorts of dancing to get it. So if you hold like this, it's easy because that's a natural rotation. And you hold, this is called the bridge and this is the sheath. So you hold both together so that one of them don't fall down. Okay. And then, so normally between these 4 fingers you hold the penis. And the lower end of the penis is the nerves, which is called frenulum, and all the nerve supply. You don't want to injure any of those things. And if you notice the cystoscope, the top is the smooth part. So when you are starting it, you go like this and then you rotate. Okay. Then you see the urethra. See, normally if you just push it in, what happens? Do you see the urethra? Yes. That's strange. I don't see the urethra, I see only one wall of the. See, if you see like this and push, what happens? It will cause injury to the urethra. So, this injury to the urethra is the most common cause of strictures. So, while trying to learn on patient, we should not make the patient suffer because of your learning process. So, that is the reason why I made these simulators, so that you don't injure the actual patients. Okay. So, now, so if you hold the penis correctly, then only you will see the lumen. Okay, so once you see under vision, you have to slowly pass it. So now what happened to the urethra? See, here it looks like a nice circle. Then here what happened? Yeah, this is because of the normal natural curves of the urethra. So how do you straighten it? Now you watch from outside. You bring the scope down. So then if you look there, it becomes straight. So you have to make sure you pass under vision. Then what is this structure called? Anybody? It is called the verumontanum. This is an important structure because it's at this level that we have the sphincter or the valve mechanism. So normally what happens is that from here, unless you move the scope correctly, if you blindly push it, it will cause a lot of injuries and a lot of damage. And most of the strictures occur in bulbar urethra or this area. So you have to make sure that you look at the veru, and then what are these structures you see on either side? That's a prostate gland, both the lobes. You saw in the earlier picture, is very close to each other, so there is hardly any space. So this is a normal prostate look, which is not enlarged. Then what is this? That's called the bladder neck. Okay. So the normal curve of the urethra is that it goes like this, then at the level of the sphincter turns up, then it goes to the bladder neck, then it dips again. Okay, so then you go here, and then you see what is called the interureteric ridge, and then you can look at the ureteric orifice. See the one hole there. Okay. And what is this? Is it look like a normal structure or abnormal structure? Okay, so we have put a stone there, so you can identify if there are any abnormal structures also. Okay. Did I hold like that or some others you tell me? Is she holding wait. Is she holding correctly or not? Huh? So what is the mistake she is making? Okay, you have to hold between, I said, the index finger, ring finger, middle finger, this. So you hold like this. So the advantage is that, just a minute. You have the index finger and thumb so that you can open normally it's closed. So you can press like this and open. Okay. So if you hold like this, again the moving will be difficult. So this is the correct way of holding it. Okay. See first this is straight. So hold it with 2 fingers, not like this, just 2 fingers. Then this is upside down. So this is 12 o'clock, this is 6 o'clock. So practice that from outside. So this is 12 o'clock, this is 6 o'clock. Okay, so first start with the 6 o'clock. Pass it upside down, inside. Okay, now once it goes inside, turn. Now only when you see the lumen, you have to pass it. See, now we have to straighten it. Okay. See, you have to adjust your left hand so that you see the thing properly. See, no, now will cause injury. You'll go and press there and cause injury. So you adjust your left. This. Okay, now you push it. Once you see clearly, you keep pushing it. See, you should not rotate. This 12 o'clock has to be constant.
अगर रोटेट कर दोगे तो आपको पता ही नहीं लगेगा कि किस रास्ते में जा रहे हैं.
Okay, so then you come there, and then the veru, then you press, then go here.
और देखो आपने थोड़ा
Okay.
रोटेट कर दिया.
So this is the orifice on one side. Then you move and go to the orifice on the other side there. Okay. Okay. Then you take it out in the same way, opposite of what you did, slowly under vision. Pull it back. Pull it back.
निकालना है आपको
निकालना चाहिए.
ग्रेजुअली.
Then turn like this. Okay. Okay. Then the next person. Who wants to do next?